Genetic nephrotic syndrome. How do you treat? Actually, 0 to 3 months age group, congenital nephrotic syndrome, you have 60 to 85% of the prevalence of the genetic nephrotic syndrome, and 4 to 12 months you have around 50%. 1 to 6 years infantile cases, you have more, and so up to under 6 you have 25%, and 12 to 7 to 12 months you have 18%. 13 to 18 years you have 11% of the genetics involved in the pathogenesis of nephrotic syndrome. So the genetic nephrotic syndrome is difficult to treat because they are usually not steroid sensitive. Only 3% of the steroid trial in the Portland data has shown they responded, but rest 97% didn't. So thereby, usually steroid is not advocated, not useful in the genetic nephrotic syndrome. What are the underlying genes? NPHS 1 nephrin, and 2 podosin, and 3 or PLCE or the or NPHS 3 and the LAM, and then this WT1, they comprise around how much 60% of the underlying genetics of the nephrotic syndrome, and other LMX and then others sleep proteins and cytoplasmic proteins, nuclear genes, and the different location genes, they are responsible for the rest percentage of the nephrotic syndrome. So thereby the genetic nephrotic syndrome presenting with a syndromic or extrarenal presentation should not be usually they are non-responsive, should not be given steroid and other immunosuppressive, even CNI. But some of the genetic cases that will present only with isolated nephrotic syndrome, isolated renal disease, and steroid resistant nephrotic syndrome, infantile and congenital cases. So genetics must be tested in those cases. If you know the gene, particular subject, you are suspecting a particular gene, you go for Sankar sequencing. When you are not certain, you can go for the little bit of broader spectrum sequencing, like next generation sequencing. When you are still not very much certain which gene is involved, you go for the more broader gene sequencing, like whole exome sequencing something. If you go for sequence more genes, certainly that will be more expensive, and knowing histology of the genetic cases may not be that important because they are not conclusively decisive about the immunosuppressive therapy, but still, but genetics they are. How to treat the genetic cases? You give the anti-RAS, renin, angiotensin, aldosterone inhibitors. Yes, inhibitor is the perhaps by far the commonest medications used over here. 30 to 40% reduction of proteinuria is seen globally, but if you use the two, the ARB along with the ACE inhibitor, you have another 15% reduction or 3 to 4 centimeter blood pressure reduction. So thereby, but at the expense of the renal impairment, hyperkalemia. So thereby, you do not give together. The giving two are not that useful. Give one, either of the two, and then apart from that, you go on giving it and see the proteinuria. You may not stop the total proteinuria, but you have some benefit, no doubt of it. And so you reduce the dose of sodium intake. Salt should be less than 2 to 3 gram, and then sugar should be less. Nutrition calories and there should be ensured. And your albumin infusion in nephrotic syndrome, genetic or difficult cases, 1 to 3 gram per day. And daily dose, 3 to 3 infusions in the daytime, and in severe cases like congenital nephrotic syndrome, you need to use those infusions at night time. In those cases, dose will be a little bit high, even up to 4 gram per kg per day you need to use because of the hypoalbuminemia and edema formation. And infective infections, you need to give parenteral oral antibiotic and preventive vaccination along with infection prevention. Hepatitis B12, for the cube mutation, CUBN mutation, and the ubiquinone coenzyme for some of the cases of the coenzyme Q deficiency, Q genetics, nephrotic syndrome. Some response might be there. And trial of CNI and other medications are said not that useful, but sometimes some study has found the partial and complete remission in some of the diseases like WT1 disease, PLC1, and MOY1E disease. Apart from that, the SGLT2 inhibitor, they are found useful at times. Your DAPA and empagliflozones and finerenone, non-selective mineralocorticoid receptor antagonist. They are also, people also trying it with some benefit. Sparsentan and your ibnesartan. These are the two dual RASI and then MRA, your melanocortin receptor antagonist. It is also found to have reduced proteinuria by 40% of the cases and 40% reduction. So in worst possible case, you have the people are thinking about giving or deciding about the medical nephrectomy in an attempt to give CNI and NSAID, the indomethacin or so forth, and then ibuprofen, and waiting and seeing for the response of the proteinuria reduction. And at times this nephrotoxic medication, what they do, they enhances fibrosis. When the whole kidney is fibrosed, small and shrunken, a patient may not have proteinuria, and these patients may subsequently should be given to a transplant with a donor who is genetic test negative, non-genetic donor.